Hello. So we're moving on to discuss assessment of the breasts, axilla, and female genitalia. And so these assessments are really important components of a comprehensive health exam, and they play a critical role in health promotion, early detection of disease, and patient education. And again, many patients are going to feel anxious, embarrassed, or vulnerable during these assessments, so it's essential that we establish trust, maintain professionalism, explain each step of the exam, and provide privacy and dignity throughout the assessment process. So we're going to review relevant anatomy and physiology, subjective and objective assessment techniques, and age-related considerations, health promotion strategies, and then common abnormal findings that may require further evaluation. So by the end of this presentation, you should be able to identify normal and abnormal assessment findings and understand the nursing implications of those findings, along with these learning objectives. So before performing a female genital assessment, it's important to explain the procedure and obtain informed consent. You're again going to provide privacy, and we're going to use a trauma-informed approach. And many patients are going to feel anxious or embarrassed during this exam, so maintaining dignity and professionalism, as well as communication, is essential throughout. So we have some structures here I'm going to highlight. So we have the labia majora, which are the larger outer folds of the skin that provide protection for the underlying structures. And inside these are the labia minora, which are thinner folds that surround the vestibule. It's important to recognize that significant variation in size, shape, color, and symmetry of the labia is normal. Then we have the urinary meatus, is the opening of the urethra. It's located between the clitoris and the vaginal opening. During assessment, nurses should observe for redness, swelling, discharge, and signs of irritation. Then we have the perineum, which is the area between the vaginal opening and the anus. And so assessment of this area is particularly important following childbirth, surgery, trauma, or when evaluating skin integrity. And finally, the anus should be inspected for skin integrity, hemorrhoids, lesions, fissures, or any signs of infection. And when we're assessing the external genitalia, we should inspect for color and pigmentation, symmetry, hair distribution, any lesions, ulcers or masses, swelling or edema, discharge, and signs of infection or trauma. Normal findings include intact skin, absence of lesions, no unusual discharge, and structures that are free of tenderness, swelling, or inflammation. And remember that normal appearance varies greatly among individuals based on age, hormonal status, childbirth history, ethnicity, and individual anatomy. So the goal is to identify abnormalities while also respecting normal anatomical variation. So this slide illustrates the major internal reproductive organs and their relationship to surrounding structures. So the vagina is a muscular elastic canal extending from the vaginal opening to the cervix, and it serves as a passageway for menstrual flow, sexual intercourse, and childbirth. And the vaginal walls are normally pink, moist, and free of lesions. And at the upper end of the vagina is the cervix, which is the lower portion of the uterus. And the cervix contains the cervical canal connecting the uterus to the vagina. And during a pelvic exam, the cervix is assessed for color, position, lesions, discharge, and abnormalities. The uterus is a hollow muscular organ. It's located between the bladder and rectum. Its primary function is to support fetal development during pregnancy. The upper rounded portion is called the fundus, while the main body is referred to as the corpus. The uterine wall contains 3 layers. We have the endometrium, which thickens and sheds during menstruation, myometrium, which is the thick muscular layer responsible for uterine contractions, and the perimetrium, which is the outer protective layer. So extending laterally from the uterus are the fallopian tubes, which transport ova from the ovaries towards the uterus. And then fertilization most commonly occurs within the fallopian tube. The ovaries are paired reproductive organs that produce that ova and secrete hormones, including estrogen and progesterone. And although the ovaries are important structures, they are often difficult to palpate during a routine exam, especially in postmenopausal individuals. But notice the close relationship between the reproductive organs and neighboring structures such as the bladder, urethra, ureters, and rectum. So understanding this anatomy helps explain symptoms such as urinary frequency, pelvic pressure, constipation, or pain that may occur within reproductive conditions. And during a comprehensive pelvic exam, healthcare providers may evaluate the cervix, uterus, and ovaries through speculum and bimanual examinations. So as nurses, it's important to understand the purpose of these assessments, assist with patient positioning and comfort, and then recognizing normal versus abnormal findings. So to understand the female reproductive health, it's important to understand the hormonal feedback system that regulates the menstrual cycle and reproductive function. This process involves communication between the hypothalamus, anterior pituitary gland, and ovaries. It's often referred to as the hypothalamic pituitary ovarian axis, or HPO for short. The process begins with the hypothalamus, which secretes gonadotropin-releasing hormone. And this stimulates the anterior pituitary gland to release two important hormones. So we have follicle-stimulating hormone and luteinizing hormone. Follicle-stimulating hormone primarily stimulates the growth and maturation of ovarian follicles, and as follicles mature, they begin producing estrogen. And then we have luteinizing hormone, which works alongside the follicle-stimulating hormone, but it plays a particularly important role in triggering ovulation. So a surge in luteinizing hormone can cause the mature follicle to release an ovum, which is the process we know as ovulation. And the ovaries respond to those hormones by producing the hormones estrogen and progesterone. And estrogen is responsible for development of female secondary sex characteristics, growth and thickening of the endometrium during the first half of the menstrual cycle, and regulation of the menstrual cycle through feedback mechanisms. Progesterone becomes the dominant hormone after ovulation. Its primary role is to prepare and maintain the endometrium for possible implantation of a fertilized egg. But if fertilization does not occur, estrogen and progesterone levels are going to decline, which causes that endometrial lining to shed and results in menstruation. So the system functions through a delicate balance of positive and negative feedback loops, and any disruptions anywhere along the pathway can lead to menstrual irregularities, infertility, or hormonal disorders. So very sensitive. Let's move on to breast exam. So before performing a breast assessment and exam, it's important to understand the underlying anatomy. So knowledge of breast structures helps us distinguish normal findings from abnormalities, and it helps us understand how disease processes affect the breast. So let's review the major structures shown on the slide. We have the nipple, which is located near the center of the breast, and during assessment, we observe the nipples for symmetry, position, inversion, discharge, scaling, or lesions. Surrounding the nipple is the areola, the pigmented area of skin. We are looking at color and size, which can vary widely among individuals, and it may change during pregnancy due to hormonal influences. And within the areola, we have small sebaceous glands called Montgomery glands, and these glands secrete an oily substance that lubricates and protects the nipple, particularly during breastfeeding. And then small raised bumps in this area are also a normal finding. And the breast is supported by fibrous connective tissue, including Cooper's ligaments, and these ligaments help maintain breast shape and structure. When breast cancer invades these ligaments, we may sometimes see dimpling or retraction of the skin. The glandular tissue, this is responsible for milk production and transport. This tissue consists of lobes, lobules, and ducts that converge towards the nipple. Much of the breast nodulary comes from normal glandular tissue, particularly in young women. And within the glandular tissue are these Acini cells, which are the milk-producing cells. During pregnancy and lactation, hormonal stimulation causes these cells to enlarge and become active in milk production. The breast also contains a rich network of arteries and veins, which provide blood supply and support lactation. Increased vascularity may become visible during pregnancy and breastfeeding. And one of the most clinically important structures shown on the slide is the lymphatic system. So approximately 75% of breast lymphatic drainage occurs through the axillary lymph nodes. The remaining drainage occurs through internal mammillary and other regional lymph nodes. This lymphatic drainage pattern is important because breast cancer often spreads first through the lymphatic system. So for this reason, axillary lymph node assessment is routine part of every breast examination. Makes sense? So to accurately communicate breast assessment findings, healthcare providers use standardized breast landmarks. And these landmarks allow clinicians to precisely describe the location of masses, tenderness, skin changes, or other abnormalities and ensure clear communication among members of the healthcare team. So there are two common methods used to describe breast findings. The first method divides the breast into 4 quadrants. We have upper outer, upper inner, lower outer, and lower inner quadrants. And an additional area called the tail of Spence, this extends from the upper outer quadrant into the axilla. This region contains breast tissue and lymphatic structures, and it's clinically important because, like we said, many breast cancers develop in this area. So therefore, assessment of the tail of Spence and axillary lymph nodes should always be included during a breast examination. The second method uses the face of a clock. So in this system, the nipple serves as the center of the clock. The findings are described by their clock position and distance from the nipple. For example, a nurse might document a 1 centimeter firm mobile mass located at the 2 o'clock position, 3 centimeters from the nipple, or tenderness noted in the lower outer quadrant of the left breast. So using consistent landmarks is going to help us improve documentation accuracy and allow providers to compare findings over time. So one of the most important roles of the nurse during a breast assessment is recognizing findings that require prompt follow-up and further evaluation. So patients present with a variety of breast concerns, including trauma, infection, pain, masses, or nipple discharge. And while many breast conditions are benign, it's important to remember that breast cancer can sometimes mimic inflammatory or infectious conditions, making careful assessment really essential. So common findings that should prompt additional investigation: a new lump or mass. It's one of the most significant findings. Although many breast masses are benign, any new mass should be further evaluated, particularly if it's firm, fixed, irregular, or persists after menstrual cycle. Breast swelling or asymmetrical enlargement. This may indicate infection, inflammation, trauma, or malignancy. So changes in the skin, such as dimpling as well, puckering, or irritation. These are concerning. Again, we talked about how they may indicate involvement of the underlying connective tissue and lymph nodes. Dimpling occurs when a lesion pulls on those Cooper's ligaments, which creates that indentation in the skin. Breast pain, this is often associated with benign conditions as well, but persistent localized breast or nipple pain warrants further assessment, especially when accompanied by other abnormal findings. Nipple retraction is another important finding. Although some individuals have lifelong inverted nipples, a newly retracted nipple should always be evaluated because it may result from an underlying mass pulling on the breast tissue. Any changes involving the nipple or breast skin, including redness, scaling, crusting, thickening, or ulceration, may indicate inflammatory conditions, infection, or less commonly malignancy. Finally, nipple discharge should always be assessed carefully. Important questions include: is the discharge spontaneous or is it expressed? Is it unilateral or bilateral? What color is it? Is it bloody, serous, milky, or purulent? Spontaneous unilateral bloody discharge is particularly concerning, and it requires prompt evaluation. So before beginning the physical exam, it's important to gather a thorough health history, as we know. The subjective assessment is often going to provide us valuable information that's going to guide the physical exam and help us identify risk factors for breast disease. So breast discomfort, masses, or nipple discharge, we want to ask the patient about any breast pain, tenderness, lumps, or changes they have noticed. If pain is present, we're assessing the location, duration, severity, and relationship to the menstrual cycle. For nipple discharge, we're determining whether, again, spontaneous or expressed, unilateral or bilateral, noting the color and consistency. Any history of breast surgeries, we want to ask about previous breast surgeries, including biopsies, lumpectomies, mastectomies, breast augmentation, or reduction procedures. Surgical history may alter breast anatomy and affect assessment findings. Menstrual, pregnancy, and lactation history, so those hormonal fluctuations throughout life include breast or influence breast tissue. So we're asking about age of menarche, which is the start of a young woman's period, menopausal status, pregnancies, breastfeeding history, and current menstruation patterns. Any breast changes associated with pregnancy and lactation, these are often normal, but should also be assessed. Hormone replacement therapy and hormonal contraceptives, we're determining whether the patient currently uses or has previously used hormonal replacement therapy or hormonal contraceptives. Exogenous hormones can influence breast tissue density, and they may affect breast cancer risk. Personal history of breast trauma and self-care behaviors. We want to ask about any recent breast injury, trauma, which can cause pain, bruising, or fat necrosis that may mimic a mass. We want to assess health promotion behaviors such as breast self-awareness, routine screening, and mammography adherence. Family history. This is a significant risk factor for breast cancer. We want to ask about first-degree relatives with breast, ovarian, or related cancers and determine whether the patient or family members have tested positive for the BRCA1 and 2 gene mutations, which substantially increase breast and ovarian cancer risk. Assessment risk factors. So we're asking about past medical history, any previous breast conditions such as cysts, fibroadenomas, atypical hyperplasia, or breast cancer. We're discussing reproductive history, including age that they started having a period, and menopause, as prolonged lifetime exposure to estrogen may increase breast cancer risk. So the younger you were getting your period, the more increased breast cancer risk you could have. We also want to determine whether the patient has undergone chest radiation therapy, particularly at a young age. This increases future breast cancer risk. And then lifestyle and personal habits, we're assessing alcohol consumption, as increased alcohol intake is associated with higher risk of breast cancer. We want to discuss physical activity levels, weight management, and dietary habits, evaluate tobacco use and exposure to environmental risk factors, encourage healthy lifestyle behaviors that support overall breast health and reduce cancer risk. Medications, we want to review any current and past use of hormonal replacement therapy and hormonal contraceptives. We want to ask about medications that may affect hormone levels or cause breast changes, and determine whether the patient has noticed breast symptoms associated with medication use. And then finally, obtain a detailed family history, especially again among first-degree relatives such as parents, siblings, and children. We want to ask about breast cancer, ovarian cancer, prostate, pancreatic, and known genetic mutations, and determine whether any family members have tested positive again for the BRCA1 and BRCA2 mutations. So one of our most important roles is promoting breast health through education, risk reduction, and early detection strategies. So breastfeeding promotion. National and global health initiatives continue to promote breastfeeding because of its health benefits for both infants and mothers. So breastfeeding provides optimal nutrition, supports infant immune function, and promotes maternal-infant bonding. So for mothers, breastfeeding has been associated with a reduced risk of breast and ovarian cancers. And so we can support breastfeeding by providing education, encouragement, and referrals to lactation resources when needed. Genetic counseling for individuals at increased risk. So patients with a strong family history may benefit from genetic counseling, which helps individuals understand their personal cancer risk and determine whether genetic testing may be appropriate. Reducing breast cancer mortality. So early detection remains one of the most effective ways to reduce breast cancer deaths. We should encourage adherence to age-appropriate screening recommendations, including mammography and clinical follow-up when abnormalities are identified. We should focus on recognizing breast changes and promptly reporting concerns to their healthcare provider. And then teaching breast examination. Historically, women were routinely taught to perform monthly self-breast examinations, but current evidence doesn't demonstrate that routine monthly breast examinations alone reduces breast cancer mortality. So many organizations no longer recommend that. Instead, they're emphasizing a strict monthly exam. Instead of that strict monthly exam, the current recommendations are focusing on breast self-awareness. So that means becoming really familiar with the normal appearance and feel of one's breasts and promptly reporting any changes. So patients seek breast health care for a variety of reasons, and as nurses, we must recognize common symptoms, understand age-related changes, and provide culturally sensitive care. So common symptoms that patients might come in with: breast pain. This is a common complaint, and it's often benign. The pain may be cyclical. It could occur with hormonal changes during the menstrual cycle or non-cyclical. So we're assessing the location, duration, severity, and relationship to menstruation. So although breast pain alone is rarely associated with cancer, persistent or localized pain should be evaluated. Rash, we're assessing the skin for redness, scaling, crusting, or irritation. Rashes may result from dermatitis, fungal infections, allergic reactions, or inflammatory conditions. Lumps, like we talked about, most breast masses are benign, but any new masses should be assessed carefully. Swelling, breast swelling may occur during hormonal changes. Could be an infection, trauma, pregnancy, or malignancy. So we're comparing both breasts for symmetry and changes in contour. Nipple discharge, we're asking whether the discharge is, again, spontaneous or expressed, unilateral or bilateral, and noting the color. Trauma, any breast trauma can result in bruising, tenderness, swelling, or fat necrosis. So obtaining details regarding the mechanism and timing of the injury. Special populations, like in pregnancy, there are significant breast changes that occur because of those hormonal influences. So the breasts typically enlarge, become more vascular, and may develop prominent veins. The areola may darken, Montgomery glands become more noticeable, colostrum production may begin before delivery. Adolescence, so breast development is a normal part of puberty. So temporary asymmetry between breasts is common during this phase of life. Breast buds may be tender during development, so education should focus on normal growth patterns and body image for adolescents. Older adults, aging results in decreased glandular tissue and increased fatty tissue, so breasts may become less firm and more pendulous due to decreased elasticity. So the nipples may flatten, the skin may become thinner. So we're continuing to encourage age-appropriate screening and breast awareness in older adults. And then cultural beliefs may influence attitudes towards breast examinations, modesty, screening, and healthcare seeking behaviors. So some patients may prefer like a same gender healthcare provider. Others may have concerns related to privacy or body exposure or discussing reproductive health. So we're using our culturally sensitive communication, we're avoiding assumptions, and we're asking our patients about their preferences. So after completing the health history, we're going to gather objective data through inspection and, when appropriate, palpation. So inspection of the breast is the first step of the physical exam. The patient should be seated with adequate exposure of both breasts. We're observing first symmetry and size, contour and shape, skin color and condition, nipple position and appearance, visible masses or swelling. We want them to raise both arms overhead, press our hands against hips, lean forward if able. So these position changes may reveal dimpling or retraction caused by underlying lesions. A complete breast exam includes a health history, inspection, palpation of the breast tissue, palpation of regional lymph nodes, particularly those axillary nodes. And during palpation, we're using the finger pads of the middle 3 fingers with light to moderate and then deep pressure. And we're assessing all breast tissue, including the talus spence extending into the axilla. We're noting any masses, tenderness, thickening, or abnormalities. If we do identify a mass, we're documenting the location, size, shape, consistency, if it is mobile or immobile, tenderness, and distinctness of borders. Translumination, this is an advanced assessment technique. It's occasionally used to help distinguish between a fluid-filled cyst and a solid mass. So a bright light is placed against the tissue in a darkened room. Fluid-filled structures may allow light to pass through more readily, whereas solid masses generally do not. Transillumination is not commonly used during a routine clinical practice because more accurate imaging modalities are available. And then diagnostic imaging and procedures, so mammography. This uses low-dose x-rays to evaluate breast tissue. It's considered the primary screening tool for early detection of breast cancer. Then we have breast ultrasound. It's often used to further evaluate findings identified on physical exam or mammography. It's particularly useful for distinguishing fluid-filled masses from solid ones. And then MRI, this is going to provide us highly detailed imaging of breast tissue. It's often used for high-risk patients for their evaluation of suspicious findings and assessment of implant integrity. And then aspiration or biopsy. Sometimes fine needle aspiration may be used to remove fluid from a cyst or obtain cells for analysis. Core needle biopsy, this obtains a tissue sample for definitive diagnosis if we're looking for breast cancer. But biopsy remains the gold standard for determining whether a suspicious lesion is benign or malignant. Equipment needed, ruler marked in centimeters. So a centimeter ruler is used when measuring palpable masses or lesions. Accurate measurements is going to allow for precise documentation and comparison over time. A small pillow or folded towel is placed under the shoulder on the side being examined when the patient is supine, and this helps flatten the breast tissue against the chest wall, making palpation more effective and comfortable. And then patient education materials, educational pamphlets or handouts may be provided to reinforce our teaching about breast self-awareness, screening recommendations, and follow-up care. Gloves, of course, should always be using standard precautions. Adequate lighting, essential for our inspection. And then patient preparation. We're explaining this procedure to our patient. We're getting consent. We're using clear communication. We're providing privacy, exposing only the area being examined, using gowns and drapes appropriately. We want to try to just create a comfortable environment that improves the quality of the examination because the patient is feeling less anxious. And considering the timing within the menstrual cycle, so hormonal fluctuations are going to affect breast tissue. So for menstruating individuals, breast exams are ideally performed 5 to 7 days after menstruation begins. This is when hormonal stimulation and breast tenderness are at their lowest. So during this time, breast tissue is generally less nodular and easier to assess. So if a patient reports a lump, evaluation, we're not going to delay that at that time because of the cycle. But ideally, the timing that I just spoke about is helpful. So the comprehensive breast assessment is included both inspection and palpation. So breasts exposed to female hormones, we'll start with inspection. So we're beginning with the patient seated and adequately draped. We're inspecting both breasts, again, for symmetry, size, and contour, skin color and condition, any visible masses or swelling, nipple position and appearance. And we're observing the breasts in several positions. Again, arms relaxed at the side, arms raised overhead, hands pressed against the hips, leaning forward if able. So these position changes, they're going to reveal subtle dimpling, retraction, or fixation of underlying tissue. And then palpation, we're positioning the patient supine with a small pillow under the shoulder being examined and the arm raised overhead. We're using the finger pads of the middle 3 fingers, applying light, moderate, and deep pressure. We're palpating using a systemic approach. And we're including the entire breast tissue, the tail of Spence, and the axillary lymph nodes. Now we have breasts exposed to male hormones. So male breast cancer is uncommon, but it does occur. So assessment is going to include inspection and palpation of the breast tissue and axillary lymph nodes. We're inspecting for enlargement, skin changes, nipple discharge, masses. We're palpating beneath the nipple and surrounding tissues for any nodules, firm masses, tenderness. And then gynecomastia, this refers to benign enlargement of male breast tissue. It may occur during puberty, aging, obesity, hormonal disorders, liver disease, or some medications. So we're differentiating diffuse enlargement from a discrete suspicious mass in that case. And then additional techniques, we have bimanual technique. This may be useful for examining large breasts. So one hand is supporting the breast while the other palpates the tissue between both hands. This technique may help identify deep masses that are difficult to palpate with standard palpation. And then lastly, we're making clinical decisions, right? So after assessment findings are identified, we're going to interpret and communicate significance of any diagnostic testing, including mammography, ultrasound, potentially MRI or biopsies. We're using our clinical judgment. So what does the test result mean for this particular patient? Along with our assessment findings, their risk factors, and the patient's concerns. And then we're prioritizing our hypothesis of what's going on, and we're taking action. So priority findings, maybe this is a new breast mass, maybe they have bloody nipple discharge or skin dimpling, a new nipple retraction, etc. So we're determining the next steps. Are we notifying the provider? Are we potentially thinking additional diagnostic testing is needed? Are we providing patient education? Are we referring to any specialists? And then we're analyzing changing findings. Ongoing assessment is going to be essential. We're comparing our current findings with previous documentation. We're asking, has the mass changed in size? Is pain improving or is it worsening? Have skin changes progressed? Is their treatment effective? And then maybe we're collaborating interprofessionally with primary care providers or women's health specialists, radiologists, surgeons, oncologists, genetic counseling. Maybe psychosocial support is necessary because a new breast cancer diagnosis is definitely going to create anxiety, fear, maybe financial concerns or transportation challenges, treatment barriers. So, gathering all of all the people we need. Maybe social work and community resources may be involved. Coming up with a plan of care, definitely basing it individually on our assessment findings and the patient's needs. Health promotion. We are always talking to our patients about breast self-awareness, education, screening recommendations, lifestyle modifications. If they have any acute concerns, what that might look like. And then we're finally evaluating the outcomes to determine whether our interventions were effective or not. And that is it for today. I hope you have a wonderful day, and I'll see you in class.